Merhaba. Öncelikle ben de kongre...
Let me thank the organizers of the Congress as well as the participants of this panel. This is going to be a surprise because the title of my presentation is wrong in the program. Regulation Disorders of Sensory Processing is the name of my title. Is my title. Neurodevelopmental Problems from Infancy to Adulthood. It's very difficult to, of course, translate this title into Turkish because there is no agreed Turkish version of this. This might be called duysal süreçleri, algılama bozukluğu in Turkish, for example. It has several names. In your clinical practice, how many of you see children between the ages of 0 and 3? And how many of you diagnose children with this with a regulation disorder? Only 2 of you. That's exactly the purpose of my presentation. I want to raise awareness about regulation disorders. This is one of my primary objectives. And one of my secondary objectives is that we are here as adult psychiatrists and pediatric psychiatrists as well. Most of the pathologies that we see in adulthood, of course, stem from that dark age of years, of ages actually, 0 to 4. And we don't know what happens in that dark age, but still we need each and every bit of information that we can get. So all these diseases that we see in childhood is called something else when you become an adult. For example, attention deficit disorder is one of these examples. It's not told very often, it's not mentioned very often in adult psychiatry, but we know that it makes the foundation, it sets the foundation of many other diseases. And the same diagnostic groups are valid for pediatric patients as well. I will try to keep my presentation as brief as possible, and instead I will discuss our DSP. I want to call this internal control actually in Turkish, iç denetim, because the ability to regulate is an internal control ability. So I will try to go through the definition of our DSP, the diagnosis of it, differential diagnosis, outcome, and conclusion. Of course, I scanned the literature to see what's new in this field before I came to this meeting, and to be honest, I was a bit disappointed because there's only a limited number of studies on this field. There don't seem to be many concerns about this diagnosis. ICB, for example, makes a reference to this diagnosis, and this diagnosis actually made its way into the reimbursement systems, but this diagnosis is not used very often in Turkish because we don't have a Turkish counterpart for it either. So I wanted to make this presentation in order to make some suggestions about future studies as well. First, let me refer to self-regulation. There's tons of information coming from different sensory sources, be it auditory, be it olfactory, and there's information coming from our inner world as well. We filter bits of this information, we suppress some of the information, or we prioritize some of the others, or we highlight some of the other bits of information. And these become obvious in, for example, attention deficit disorders, perception disorders, or other disorders in adults, in schizophrenia. But how does this happen? Starting with an early age, the children have to develop the ability to either suppress or highlight some of these sensory inputs. At an early age, these come into being in the form of eating disorders, sleep disorders, and crying, excessive crying. colic babies, for example, the earliest manifestation is in the form of gas pain. Many children experience this, and then at 6 months, regulation starts actually, and at 6 months, 80 to 90% of sleep problems disappear. You reach homeostasis at eating as well. So a healthy eating pattern is achieved after the first 6 months of life, but approximately 20% of children cannot develop this pattern, and these children are diagnosed with RDSP. A study found out that 7% of children who were diagnosed with RDSP continued to experience this problem at later ages, at later phases of life. There are 3 problems: behavioral, sensory, and there are sleeping problems, eating problems, and excessive crying, as I said before. And there are people who think that these 3 qualities should make their way into differential diagnosis, but De Gange, for example, is one of those authors that published a lot on this issue. And this is a diagnostic group that is very difficult to diagnose. So in addition to restlessness, he claims that there should be other problems, such as eating problems or sleep problems. And I think this is one of the basic confusions, basic problems in diagnosis. We can't reach a consensus, but many people agree that these children cannot relieve themselves. They cry a lot. They're grumpy. They're impatient. These are the biggest complaints of the parents. And one of the prominent factors is that the shift from sleeplessness to sleep is very rapid in these children. They fall asleep right away, and they don't wake up gradually. They wake up crying, for example, or shouting. These are the most striking symptoms, and this is what we expect together with RDSP. They have reaction to loud sounds and noise. They have very little or high reaction to bright light. They're mostly hypotonic. They have motor coordination problems. They have difficulties in motor planning. They have language problems and attention problems. So we have sensory problems and motor problems and attention problems at the same time. This is needed for the diagnosis of RDSP anyway. It has some subtypes as well, and I believe that they're important because in many diseases, such as bipolar disease and psychotic diseases, we see a very refined definition. The episodes become isolated, for example. They're no longer intertwined. There are no mixed qualities anymore. We don't see negative and positive symptoms at the same time, but we see them in a standalone fashion. And this goes along. This is true for infancy as well. And later on starts the branching. In order to understand how that branching will take place, we have to make an early distinction. Because if we come up with a too general diagnosis, then actually we get lost. Some of them, for example, develop attention deficit later. Some develop anxiety disorders, some depressive disorders, some mood disorders or behavioral disorders. So we have to focus on the subtypes, actually. These subtypes were not studied for long periods of time, but if they were studied enough, then they would give us enough idea about the types of diseases that these children might develop in the later stages of life. So here are some subtypes. There's these hypersensitive type, which can be divided into two further subtypes. One is fearful cautious, and the second one is negative defiant. So one is more introverted. The reaction is in the form of silence and introvertedness, and some others are more negative and defiant. In the hyposensitive subtype, this time there's underreactivity to sensory stimuli. The second group is sometimes confused with the autism spectrum. It has some similarities with the autism spectrum. Of course, in differential diagnosis, we have to separate these two conditions from one another. But actually, 50% of the symptoms in the second subgroup are the same or overlap with those of autism. My interpretation is that general regulation disorder maybe seems to be a general diagnosis, but this kind of a developmental disorder has its own course. You cannot confuse it with other diseases, but ADHD starts showing some symptoms even at the age of 1, and it follows a different course. So the main purpose of all these systems, is to develop a common language so that we can set clear limits for interventions. But the difficulty with these disorders is that these diagnoses will no longer be valid at the age of 10. Therefore, we cannot run test or retest or verification studies on this group, because these diagnostic criteria are developed to define the problems at that age group. The fearful ones are not open to change. They fear and stay away from new situations and people. They become very anxious when they're away from their mothers. The negative and defiant group are made up of children who are very reactive. I will skip these slides and I will move on to long follow-up studies, because I want to see if we have the data at hand and how this disorder evolves in time. I will skip the differential diagnosis. Early stage regulation problems have an impact during school age and later during adolescence as well. 70% of these children continue experiencing problems in later stages of life. These children most of the time turn out to be children who are hyperactive, who are impulsive, who have oppositional behavior. But the age of 10 or 11 is like the crossroads, because this disorder at that age can go both ways. I'm sorry, my slides are in English, so I'm having difficulty orientating myself to my slides. But children who have regulatory disorders at an early age usually received a BPD diagnosis at school age, except for the hyposensitive group. But some others move towards anxiety or bipolarity. Hypersensitive group shows anxiety disorders, and type 3, that is, type 3 continues to experience impulsive problems or attention problems. Let me say a couple of words on the prevalence of RDSP. We have a poster on this as well, poster number 36. It's the poster of a study that looked into the reasons for taking these children to a clinic between the ages of 0 and 3. Most of the time, it's aggression and hyperactivity. Sometimes they don't respond to instructions or to orders. And they have problems with their language skills, and that's why they're brought to our clinic. So we can say that maybe 50 to 60% of the children who are brought to this clinic should receive this diagnosis. The prevalence studies show us the following data. Well, these problems are very common in Turkey, for example. A study from Turkey showed. A study was carried out on 2,775 children between the ages of 1 and 3.5. 50% of the parents said that their children are active. Only 10% of the parents think that this is a psychiatric problem. So actually 1 out of 10 infants should actually receive this diagnosis. Therefore, it's a very common problem. So here are some conclusions. The findings so far show that regulatory symptoms and related problems may well persist beyond infant and toddler age. Actually, the follow-up studies that we have up to now are only 5-year or 10-year follow-up studies. We need longer follow-up studies. This disorder evolves into other disorders as time passes. If we don't have a retrospective approach, then we can diagnose a patient, for example, with anxiety disorder, but if we look back into the history of the patient, then we can end up finding some regulatory disorders as well. So my final remark is the following. Our CNS motivation, 95% of our CNS motivation is finalized up until the age of 4. Up until then, brain is very sensitive to reactions. So early interventions on the brain has a huge impact. And we know that pharmacological therapy is now indicated at earlier ages, which is definitely needed, because this is an impact on the efficacy of the therapy as well as protection. Thank you.